about instability of the wrist. So there are several different levels of instability in the wrist. Gross instability comes from the extrinsic ligaments around the wrist, primarily volar and dorsal. Intermediate stability comes from the intrinsic ligaments, which are the ones that we have been typically in the past most interested in radiology. And then fine-tuning really comes from the triangular fibrocartilage. So there are a number of different classifications of instability. One is dissociative versus non-dissociative. So a dissociative type would be an intrinsic ligament tear, the classic one being the scapholunate ligament tear, where you get separation between the scaphoid and lunate. The other type is non-dissociative, which is really an injury of the extrinsic ligaments, where you do not get separation between the scapholunate ligament bones or sliding at the lunar-triquetral ligament that we'll talk about. Another way to classify instabilities is to look at the central column, which is dorsal intercalated segmental instability and volar segmental instability, which we'll talk about, which is the most common type of instability that's discussed really in the radiologic literature. Then you have medial instability, which is just at the triquetral hamate level or the triquetral lunate dissociation. You have proximal instability, which is really at the radius and ulnar carpal ligament tears. And then there are other types of classifications as well. The primary one that we'll be talking about will be the DC and VC type instabilities. Another way to classify instabilities is to look at mid-carpal instabilities, where you have carpal instability dissociative, or CID, and that's instability within a carpal row caused by intrinsic ligament injuries, such as scapholunate ligament or lunar-triquetral ligament injuries. And then the non-dissociative, which is the external ligaments. Complex carpal instability would be a combination of these. And then there's an adaptive carpal instability, which is really not seen when you're stationary, but with kinematics, abnormal kinematics. So let's talk about mid-carpal instability, and you can have them from the palmar side, the dorsal side, the ulnar side, or the capitolunate area. So if we look at the extrinsic ligaments, there are the volar extrinsic ligaments, which are the radioscaphal capitate ligament, and these are really just thickenings of the capsule, like we've seen ligaments in some other joints as well. Then there's the radial lunar-triquetral ligament, which is a thickening of the capsule going across the volar aspect. The radioscaphulunate, the long radial lunate, the ulnar lunate, and the ulnar triquetral ligaments. All these little ligaments in through here. So you can look for these, but most of if you have the extrinsic carpal ligament injuries, they typically don't go to MR imaging. They're typically grossly unstable, and they go to surgery. So if we want to look at these ligaments, this is an arthrogram. This is a coronal plane on the volar side. That's the ulnar triquetral ligament over there. That's the radial lunar-triquetral ligament coming across, and the radioscaphal capitate ligament a little bit more distal like that. So if you look for these, especially if you give arthrography, you can often see the outline of these ligaments. But again, we typically don't image these ligaments so much when they're torn. And there we can see the volar ligaments. If you do a sagittal image through there, you can see the radioscaphal capitate and the radial lunar-triquetral ligaments here. And if you look on the sagittal images, we can often see these on the proton density fat suppressed images. And then here's the axial images showing the two in the axial plane. The long radial ligament radioscaphulunate ligament we see here over on the radial side, and here we can see a lot of edema and extravasation of contrast that's due to a tear of that ligament on the radial side. And then here we can see a disruption of the volar radial side ligaments on these axial and sagittal images. Now, the dorsal extrinsic ligaments are primarily the intercarpal ligament, which goes right across the dorsal aspect of the carpal bones, the radial scaphoid ligament, and the dorsal radial luno-triquetral ligament, which are often multiple. And again, these are really thickenings of the dorsal capsule. And often the dorsal ganglion cysts you see will be fluid from extravasation of the capsule in between these ligaments dorsally. So let's see, Ashu, this, what do you think of this case?
So this is a 21-year-old female, status post fall injury 3 weeks ago, evaluated for third CMC joint injury. There's a few dorsal ganglion cysts there. I'm looking at the, it looks like a lot of edema, maybe along the dorsal aspect of the third CMC. Okay, and you can, okay, so this is two sagittal images comparing the second and third carpal metacarpal joint, and you can see along the dorsal aspect of the third CMC joint that ligament is absent or torn. And there may be some capsular injury there with edema.
Yeah, where it's intact on the second.
On the second, yeah, but it's torn on the third.
Torn on the third, that's right, and a little bit of bone edema right next to it. And this was a dorsal capsular tear with a little trabecular bone injury there. Good. Okay, Michael.
I guess I'll go ahead and take this case.
Right, I'm sorry. Thank you. Michael's not with us today. I forgot. Jennifer, go ahead.
49-year-old male with a fall 6 days ago, rule out TFCC tear. It looks like there's linear transverse decreased signal along the distal radius and surrounding marrow edema. I'm concerned about an intra-articular radial fracture.
Okay, so here's the fracture down here.
Yeah, so we can see a mildly displaced intra-articular fracture of the distal radius, as well as there is some tilt of the lunate.
Yeah, this is probably just, we'll talk about this. This is probably just kind of within normal. This would be a borderline tilt. And then
Okay.
what do you see of the dorsal capsular ligaments here?
Okay, so there is some fluid and just along that proximal carpal row, so they may have an injury of the dorsal capsule.
Yeah, so that was a dorsal capsular ligament tear back there. On the axial images, you can see it a little bit better. See this edema pattern and interruption of the normal black dorsal capsule here due to the capsular tear.
This is a surgical case, so that's just a nice place to enter the joint right there.
Good. And on the T2 cubes, we can see that tear very nicely here.
Campbell's uses a little different sequence of events in terms of describing the instabilities, but you all get within the same place.
Good.
With just using different verbiage.
Right. And so this is what the normal dorsal capsular ligament looks like, and this is a torn dorsal capsular ligament. Okay. Ashley, what do you think of this one?
Sorry, muted. Okay, 18-year-old male with ulnar-sided pain following a football injury. Looking at is that PD fat set imaging on the left, looks like there's some marrow edema of the scaphoid, or I don't know if that's coil artifact, but it looks like there's some marrow edema of the scaphoid in the distal radius. And then there's irregular, it looks like it's almost like is that a fractured ulna distally? And
yeah. Good.
Intra-articular fracture.
We're a little bit out of it, but that's a fracture right there.
Yeah.
Here's another slice.
Yeah, it looks comminuted, It looks like there's quite a bit of, and now you can see the marrow edema a lot more clearly. I thought it was coil artifact maybe, but it's real. And then the TFCC doesn't look normal. It looks like the central articulating disc is torn. I don't see any TFC there. No.
Yeah.
Okay.
And this is where the radioscaphoid ligament insertions would be. And this is carpal instability. This is non-dissociative.
The alignment is not normal, so there are ligamentous tears, obviously.
Yeah.
Scaphoid is not lined up properly. The distal ulna is fractured.
And there may be a little tiny separation here. They thought, this is from Nebraska, they thought that this was a non-dissociative type, so that the carpal bones were aligned pretty well. That they thought that this was an injury to the volar ligaments and a styloid fracture, ulnar styloid fracture.
Using Campbell's verbiage.
Okay. And then here we can see a lot of abnormal signal over around the ulna. Okay.
This is a surgical case.
Yeah. And we can see some injury patterns here with some edema. Okay, and then more commonly what we use the MR for is looking at the intermediate types of instability, which really end through here, which we can talk about now. So intermediate instability are typically divided into dorsal intercalated instability due to ligament tears or fractures, and it occasionally can be seen with ligament injuries from chronic inflammatory disease. Volar intercalated instability or ventral intercalated instability, also from similar injuries. You can also have fracture dislocations, and distal radial ulnar joint injuries can be put into this category. Now, one thing to realize that positioning of the wrist is very important in looking at the patterns of the bones. And that's why when I used to work just at one center and had control over the imaging more so, I would always image patients in a plastic wrist split, as we talked about before, to make sure that the positioning was the same every time. Because if you radially deviate the wrist, you'll create a pattern that looks a lot like a VC type instability pattern. And ulnar deviation really does the opposite. Now, when you think about the risk, you've got multiple layers of bones that are all tied together by flexible tendons, and therefore you can get very complex instability patterns because of that. And the wrist normally works under axial loading, so if you have instability, it can have a significant impact upon the function of the wrist. And as you know, it's composed of two carpal rows, a proximal row and a row in between. So we typically, when we look for this type of instability, we like the midline sagittal images, where we go through the central portion of the capitate as well as the lunate and radius. And normally they should align very nicely together, where the arcs here of the different articulations, if you draw a line right through the center of those, it's fairly collinear or a nice curved, smooth surface. Now, some people like to say when you start developing instability, it's like a slider crank. Whereas since a lot of people aren't used to working with old cranks and so forth, this can be a little bit confusing. But you basically can get instability at both the proximal, distal, or both rows. Typically, what happens though under axial loading is what you have is there's a tendency for the scaphoid to flex forward and the triquetrum to flex dorsally. In fact, you know that, as we talked about before, if you have a fracture of the scaphoid, the distal end tends to flex forward because those are the pressures within the wrist. And when that occurs and the bone is no longer stable, you end up with instability. So what we look for then is to see if there are changes in the positioning of the bones, which would be consistent with a loss of the normal mechanical integrity of the system, which typically would mean then that you have the lunate either flexed proximally or dorsally or volarly, and either one is abnormal, which indicates instability. And so the most common are due to unstable fractures of the scaphoid is the dorsal intercalated segmental instability, or a scapholunate dissociation, which typically leads to dorsal intercalated segmental instability, and the lunar triquetral dissociation, or occasionally a triquetral fracture, which leads to the opposite motion. Because again, the scaphoid holds the distal wrist back, the triquetrum holds the distal wrist forward. So if either of those fail, or their bony or their ligament insertions fail, then the wrist will go in the direction that opposed to the force of that particular bone. Okay, let's just go here. So then typically what will happen is if you have a scaphoid fracture, the distal part of the scaphoid will flex forward. That's attached to the distal row, which would include the capitate, causing the capitate to flex forward. The proximal part of the scaphoid flexes backwards, which is connected to the lunate, if these are connected together, which causes the lunate to flex in the opposite direction. Actually, so I'll come back to how those work and what it looks like on images in just a minute. We talked about Golula's arcs before, which we always look at both on plain films and MR to see if there are any abnormal kinks in these lines due to abnormal displacement of the bones in the coronal plane. And remember, most injuries are either distal injuries or proximal injuries in one of these two planes, greater arc and lesser arc. So when we're looking for the positioning of the bones, if we have X-rays, you typically can look at the size of the radial scaphoid, and it's typically between 10 and 13 millimeters, and the radial inclination is typically between 21 and 25 degrees, and you can see nice, smooth Golula's arcs, all three of them here in this location in a normal. If we look at the lateral X-ray, there are three lines that you can draw. One is a scaphoid line, which goes from the distal volar aspect of the scaphoid to the dorsal volar aspect of the volar cortex of the scaphoid. So that would be the scaphoid line. There's a lunate line where you bisect the distal dorsal edge of the lunate and the distal volar edge of the lunate, draw a line across there, and then draw a line perpendicular to this line that goes right through the center of the lunate. That's the lunate line. And the capitate line is the line going down the long axis of the capitate. And so there are several angles that you generate here. One is the capital lunate angle, which is this particular angle here, and it should be less than 30 degrees. If it's greater than 30 degrees, it means the lunate is dorsally subluxing with respect to the capitate. And that's typical of a DC type instability pattern. And often when that happens, the lunate gets narrower here, the capitate comes closer to the radius, and you get foreshortening of the wrist as well. And then there's the scapholunate angle, which we can see right here, which should be between 30 and 60 degrees. And that's abnormal if you have a fracture of the waist of the scaphoid and the distal part of the scaphoid flexes forward, then this angle will increase to where it's too large. So in the pathophysiology then, the scaphoid tends to pull the hand dorsally, and therefore if you get a fracture of the waist or if you get a scapholunate ligament tear, what will happen is then the hand will then tend to flex forward, which is abnormal. When that happens, you'll end up with a DC type pattern because you get flexion of the scaphoid and extension of the lunate, and that gives you a DC type pattern. The triquetrum pushes the hand forward, so it counteracts the forces of the hand from the scaphoid, so the two balance each other. But if you have a lunotriquetral ligament tear, which are pretty uncommon, then you get flexion of the lunate, and that leads to a VC type pattern. So here we can see a typical VC pattern where if you draw a line, the lunate line, and compare it to the capitate line, you see that the lunate has subluxed dorsally, the capitate volarly, and this would be a VC pattern. This would be the normal pattern where the two lines are pretty collinear, and then a DC pattern is where the lunate subluxes anteriorly, and the capitate subluxes posteriorly, and you then end up with an abnormal capitate lunate angulation as well. So these are the two, but by far the most common one we see is the DC type pattern because the most common injuries are scaphoid waist fractures and scapholunate ligament injuries. Okay. So here's a normal low field MR scan very early on, and which shows a kind of a typical appearance. This is with mild dorsiflexion of the wrist, which is kind of a neutral position, where you see a nice kind of normal curvature of the wrist in the midline. Here we can see dorsal displacement of the proximal capitate with respect to the lunate, volar subluxation of the lunate with a dorsal tilt, and this is a DC type instability pattern. And if you draw the angles here, this is greater than 30 degrees. This is within normal limits. Okay, let me see. Jennifer, what do you think of this case?
Okay, so here it looks like there is irregularity of the scaphoid waist. It looks like there may be some cortication. I can't tell if this is chronic. Here on the sagittal views, it seems like some of the margins are corticated and there's some volar displacement of the distal scaphoid fragment.
Yeah, so you have distal flexing of the scaphoid. So the scaphoid is no longer holding the wrist backward. The hand backward. So the hand moves forward, flexes forward, and the lunate is no longer held in place. So it subluxes as well, and you end up then on the sagittal images, you get subluxation of the lunate here, you get flexion of the distal aspect of the scaphoid, but the proximal aspect subluxes dorsally, and you end up with a DC instability pattern. So this is the characteristic DC pattern that you see with a scaphoid waist fracture. And this is subacute. It actually, in a normal person, if you have a waist fracture, it actually takes weeks to months for all of the laxity to develop, which causes the instability. So you really want to treat this very early on before the stresses on the ligaments and bones produces this kind of instability pattern. And here's a arthrogram showing a DC type pattern where you have dorsal tilt to the lunate and a little bit of dorsal motion and the capitate, foreshortening of the wrist, and a DC type pattern. And if you actually do all the measurements, they're abnormal here.
Normal is 30 to 60.
For this angle, yeah, for this angle.
According to Campbell.
Yeah, the normal for this one is less than 30. For the scapholunate, this is the normal angle that we measure, and this should be under 30. If we look at the scaphoid axis. Let me go back to the slide that shows that. Here we go. So here would be the capital lunate angle. That's the one we usually measure. That should be less than 30. If we go to the scapholunate angle, which is this one, it should be between 30 and 60 degrees.
Right, right. That's what Campbell's uses.
Yeah, scapholunate angle. So then if we go back to this case, so this is the scapholunate angle. This is greater than 60 degrees. That's abnormal. This is the capital lunate angle here, and this is greater than 30 degrees, so that's abnormal as well. So this indicates a DC type instability pattern on X-rays. Okay. Okay, and here's another example on an MR examination. Actually, these aren't the best lines in the world, but anyway, that's the capitate axis, the lunate axis, and the capital lunate angle is greater than 60 degrees, and that's abnormal. We can also see there's a little bit of volar motion of the capitate with respect to the lunate and radius, and a little bit of foreshortening here as well. So that's kind of mild DC type pattern. Ashu, what do you think of this case?
All right, so on the first sagittal image, we can see obvious distal deformity with dorsal tilt of the lunate and dorsal migration of the capitate. On the second image, I think that's a fracture of the waist of the scaphoid.
Yeah,
there.
It's kind of partial voluming there, but that's right. That's a scaphoid fracture with the DC type instability pattern. Good. Okay. I don't know, this just shows a distal scaphoid fracture. Here's which we can see there. Now, I think we saw this case before. Here's a healed scaphoid waist fracture here, which is now intact. But what we see on the sagittal images is it healed in an abnormal configuration where the distal aspect of the scaphoid is forward flexed on the proximal aspect, and this produces a typical bony prominence dorsally here, which is called a humpback deformity. So as we talked about before, you want to treat these before you get a fixed deformity like this, because this then leads to instability, which is very difficult to treat. Now, if you don't treat this and you develop instability, the instability of the wrist leads to degenerative disease of the carpal bones, and it's called a SNAC wrist or a scapho non-union advanced collapse. And there are different degrees of it. Early on, you just get degenerative changes here at the involving the distal radius and the distal aspect of the scaphoid. You get more disease, you start getting more disease between the scaphoid fragments and the capitate, and finally it spreads to involve all of the radial aspect of the proximal wrist, as we see here. And then also you tend to get more and more tilt to the lunate and more proximal migration to the capitate, to the point where you can even actually have a dislocation of the lunate and direct articulation of the capitate with the radius in severe examples. So Jennifer, what do you think of this case?
So here we can see a chronic appearing fracture of the scaphoid waist. There's cortication of the fracture margins and cyst formation, and there is dorsal tilt of the lunate compatible with DISI.
Yeah.
And there's also articulation of the radial styloid with that distal scaphoid fracture fragment. So this could be developing SNAC wrist or degenerative changes of the distal radius and scaphoid.
Yeah, so in the one grading system, typically you get early disease in through here, which we don't see very much now. Intermediate disease you start getting in the fragment itself, and then you start getting disease that involves the capitate. This is really intermittent along that disease pattern. We can see, again, a little bit of dorsal displacement of the capitate and proximal migration. So this really is a SNAC wrist. Act 2. Okay, and here again we can see, in this case, we can see actually a little bit of a, again, volar displacement of the capitate. This is dorsal displacement of the lunate with rotation, proximal migration, a lot of degenerative disease here. And here we can see the fracture. So this is a more severe disease. Now, if you have acute trauma to the wrist, it can involve the ligaments producing fractures in typical displacement patterns. And a common pattern is displacement of the lunate. So often on the sagittal images, when you see these acute injuries with instability, the lunate is kind of the key bone that people like to look at. And if you have a perilunate dislocation, what happens is the lunate stays pretty much in place, but you have dorsal displacement of the capitate and the distal carpal row. With the mid-carpal dislocation, what you have is the carpal row only mildly, the distal carpal row only mildly displaces dorsally, and you have the lunate flexed and dislocated anteriorly, and then you can have a lunate dislocation where the capitate is normal in position and you only have the lunate dislocated anteriorly. And the one on the right is thought to be the most severe form of the disease. So you can grade these from normal, perilunate, midcarpal, and lunate dislocations based upon these findings.
They all have to be reduced and fixed. So that, no matter which one you get, that you have to fix it. Usually you can't do it without a surgical procedure. And one of the things you do here is that this is a hand surgeon's territory. This is not a general orthopedic surgeon's territory.
Yeah. Okay, now looking at scapholunate ligament tears, as you both already know, is you can have tears in the membranous section. They're basically three components of the scapholunate ligament. One is a volar component, another is a dorsal component, and the other is a membranous component. Now, back in the days when we did arthrography of the wrist using X-rays, what we typically did is we could inject all three compartments, but typically we would inject the mid compartment and see if contrast would extend through a membranous tear into the distal compartment. And then we would call a scapholunate ligament tear. And it turns out that if that's the only part of the ligament that's torn, you have a stable injury that typically does not require treatment. So a lot of the injuries that we were looking at before were not really surgically important tears. In fact, close to 50% of wrist in 50-year-olds and older individuals will have a stable membranous components tear. So that's really not the kind of tears we're really looking for. The unstable tears are the ones that involve the dorsal or volar ligaments, because these are much tougher ligaments. The membranous portion is very thin, and it is not really responsible for stability of the joints. So what we really want to look at are the dorsal and volar tears. The membranous tear, I think, is best visualized in the coronal images. The dorsal and volar tears are best visualized in the axial images. So we've really gotten away from wrist arthrography as we've better understood the injuries that are important in the wrist. Wrist arthrography may be helpful in scapholunate ligament tears, but there are problems. Its sensitivity is debated, but it's nowhere close to 100%. What can happen is you can have significant tears of the dorsal or volar ligaments, which scar down, and contrast will not go through them, and you can have a false negative. And on the other hand, you can have a tear of the membranous component, have intact dorsal and volar ligaments, have a positive arthrogram, but have a very stable lesion. So, especially in people over the age of about 35 or 40, wrist arthrography is not very helpful in evaluating instability. Now, A lot of the instability patterns that we're talking about hinge around the lunate, as we talked about before. So a lot of discussion has been discussed about perilunate instability, and it tends to initially involve the dorsal scapholunate ligament, but let's just go forward here. So so here's an arthrogram. Jennifer, what do you think of this?
Okay, so we have T1, T1FS, and STIR images. I don't see any contrast signal intensity extending along the region of the scapholunate ligament on the T1 images. So I think the scapholunate ligament is intact.
Okay, so we certainly don't see any contrast going through there. We see a little bit going into the distal radial ulnar joint and into the recess over here, the prestyloid recess. And we already saw this case before where you see contrast going into the mid-carpal joint space. Scapholunate ligament was intact, but they over-distended the wrist, and you can have contrast either going around the scaphoid, which we had here, or you can have contrast going into the piezoform triquetral joint space and then into the mid-carpal joint space, which we talked about before as well, which can give a false positive. So really, I think in order to look for instability here, you look for the pattern in the bones, and then you look for the dorsal and volar scapholunate ligaments to see if they're intact. Sometimes arthrography can help visualize these ligaments, but I wouldn't do arthrography just to do that. I think with good quality high field imaging, we can evaluate those ligaments quite nicely. And this was a case where we had contrast going into the mid-carpal row through a membranous tear, but the dorsal and volar ligaments were intact. So this was a stable wrist with a positive arthrogram. Okay, Ashu, what do you think of this
one? Looks like there's a little bit of contrast extending along the in the second carpal row, and I'm just wondering if there's if I can see the axial sequences, there might be a tear. Oh yeah, okay, so there's central perforation.
There was a little central perforation. Hard to see here.
Yeah.
But here are the axial images.
All right, so in the axial images, I think the dorsal capsular, the dorsal looks okay. Maybe it's a little frayed. And then the volar aspect, it's kind of thin, but it's intact.
Right.
Hmm.
Yeah, so that was another membranous tear that was stable.
Okay.
Okay. And then here we can see, it doesn't look like a lot of displacement here. There's an erosion here of the lunate, type 2 lunate. And there we can see the fluid going through the membranous tear. So this was central perforation, but it was still stable. Okay, Jennifer?
Okay, so this is a 68-year-old female with wrist pain 3 weeks after a fall, rule out fracture. Just on these T1 images, I don't see any definite fracture, but there may be some widening of the scapholunate interval and some dorsal tilt. Is this the lunate? So I think there may be a scapholunate ligament injury and instability. Okay, and then here we have the sagittals where we can see there's a complete tear of that volar scapholunate ligament with fluid signal intensity.
We really don't see a good dorsal either. Maybe a little junk in here, but not good. Here's the CT scan.
Yeah, here we can see widening of the scapholunate interval.
Yeah, and so this was a complete tear of the volar and a high-grade partial tear of the dorsal, and also a tear of the membranous portion. So this was an unstable injury. Okay, Ashu.
25-year-old male with lateral post-traumatic pain. You can see contrast extending to the second carpal row. You can see some dissociation of this scapholunate ligament. I think there's a tear there. I'd like to see the axials. Okay, so here it almost looks like there's an avulsion of the volar scapholunate ligament there. I think I seem to, I don't know if that's a bone fragment.
No, I think this is an avulsion of the volar ligament. Maybe a little bit of strain of the dorsal ligament, but it's probably intact.
Yeah.
And there we can see.
Yeah,
and this was an unstable injury.
Yeah.
One thing about surgery in this area, a lot of autogenous grafting is used from tendons in the wrist. So what they do is strip a tendon and make a suture out of it, and then drill holes through the bones that you want to fix in place, and then you put the ligaments through the bones and weave them in and out the way you want to stabilize the bones. It's a very interesting, intricate way of doing things, and but in an acute situation, that's what you do, and the results are pretty good. They talk about like 90%, which in orthopedics is very good.
Yeah, very
otherwise, if you wait, you cannot do any of these things. What happens is you start doing fusions. You do one fusion, then you do another fusion, etc., and it keeps on going, depending on how active a person is. So it's late, it's fusion. Early, it's ligament replacement, i.e., using autologous tendons.
Okay. Thank you, John. Let's see, who's next?
I think that I'm next.
Okay.
This is an NHL player with pain for 2 months. We can see there's widening of the scapholunate interval with disruption of I would say all of the components of the scapholunate ligament. I don't see any normal fibers on this image.
Yeah, but we only see the membranous on this image, but you're right. The others have to be torn in order to have displacement like this.
And there's also some increased signal there in the TFCC, kind of near the, I don't see the foveal attachment or the styloid attachment very well, and there's contrast.
Here's the foveal attachment right here.
Okay.
So
I guess there's a tear of the disc with contrast extending into the DRUJ.
Right. There you can see it also. And a little bit also going into the recess over here. And there you can see the membranous portion tear, or the axial images.
Okay, so here on the axial images, it looks like there's a complete tear of the dorsal scapholunate ligament and also some high-grade tearing of that volar ligament.
Yeah, they were both torn. Good.
Yeah.
Yeah, so they had a bunch of tears there. Okay. Ashu.
All right. Looking at two coronal imaging here, there's some widening of the scapholunate interval a little bit. Maybe there could be some signal extending through there, and that could be torn. And then there's also maybe a tear on the lunar triquetral side. That's kind of where that's just a recess. I'm not quite sure. I'd like to see.
Right.
Okay, so that's real.
So these are tears of both, right. And you can see a little bit of contrast extending into the mid-carpal row here. Now with lunar-triquetral ligament tears, you tend not to get diastasis in the bones. What you get is a sliding the triquetrum with respect to the lunate, not dissociation. So that means it's fortunately it's much less common than the scapholunate, but it means you really have to look at the ligaments themselves to look for instability here, as well as the whether you have a VC type pattern on the sagittal images, because you actually don't get widening of the joint space here, just sliding. Okay, so here's a 36-year-old professional hockey player, wrist pain for 1 year, and here we can see increased signal intensity going through both ligaments as well, with probably a little bit of chronic repetitive impaction of the base of the triquetrum in this location. Gradient echoes, we can see a little bit of diastasis here at the scapholunate, but not at the lunotriquetral ligament. And here's the PD fat set, just what these tears look like with different kinds of contrast images. And then also a little distal scapholunate ligament insertional tear, an inferior laminar tear involving the triangular fiber cartilage as well. So again, okay, Jennifer.
Okay, so here again we can see increased signal and marrow edema in the ulnar proximal aspect of the triquetrum, and there's also edema within the proximal lunate. So I would be concerned about the lunotriquetral ligament and would check to see if it's intact. And I do not see the TFCC attachments to the ulna very well on this image. There's a large amount of fluid in the DRUJ, so there may also be a tear of the TFCC, and there's also some widening of the scapholunate interval compatible with a tear of the scapholunate ligament.
Yeah, so this is scapholunate ligament tear. There's also a tear of the triangular fiber cartilage. And we'll talk about grading the TFC tears as well. This would be a type 3 because the other ligament stabilizing ligaments of the triangular fiber cartilage were also torn. So we'll talk about that later. Okay, Ashley, what do you think of this case?
17-year-old male with wrist pain after a sports injury. It looks like there's fluid extending through both the lunotriquetral and the scapholunate ligament. I think I'd be worried about.
Certainly you see it coming through the membranous portion here, maybe here.
Maybe there, yeah.
But I'm not so sure. Here are the axial images.
Okay, so there's the scapholunate dorsal ligament doesn't look completely normal. It looks a little, at least high-grade partial tear.
Yeah, it's a little thick, and either that or tendinosis. The volar one looks fine.
Yeah.
And this was a stable instability pattern. I think this is enough of an intact dorsal ligament that it's going to be stable. So this was primarily just a membranous tear.
Okay.
Okay, Jennifer.
Okay, so it looks like we have coronal and axial images with intra-articular contrast, and there's complete disruption of the scapholunate ligaments. There's contrast extending into the mid-carpals, and there's also edema. Well, there's contrast within the TFC disc as well. They may also have a tear of the TFCC.
Yeah, but we don't see any contrast going actually into the distal radial ulnar joint.
Right.
And this was a scapholunate ligament tear, and also kind of a tear that there was also a partial tear of the lunotriquetral ligament, but that wasn't thought to be significant. Just the scapholunate ligament tear, and we can see the dorsal and volar components are not intact here. Okay. Ashley, what do you think of this one?
So it looks like there may be some on the left side. Is that the abnormal side? I see some cystic changes along the distal pole, the scaphoid.
You gotta tell us which side is abnormal.
Yeah, that's what I'm guessing. Okay, and then
Wait a second, just a second. I've got to remember. I don't know why I have these oblique images up here.
They're obviously different.
We certainly
different.
see the degenerative changes here. Yeah, these are oblique. So here we can see that the lunate is pretty normally oriented with respect to the capita.
But the scapholunate angle on that prior image looks, that second image, it looks like the scaphoid is almost horizontal.
Yeah, it has a fracture, I think, on one of the views that we just saw.
There's the scaphoid, but there's the capitate up here.
Yeah. I thought the scapholunate angle was abnormal there, but I could be wrong.
You're probably right. Yep, that's probably, and the capitolunate angle is normal, but the scapholunate angle is abnormal. Good. I think that's what this was supposed to be showing, and this is of the left wrist. And we can see degenerative changes already forming here. Okay, and here's the MR.
The fracture.
Yeah, I don't know for kind of volume averaging, but yeah, that scaphoid does not look normal proximal pull, and there's definitely a complete disruption of the dorsal scapholunate ligament and scapholunate interval widening there.
Right. Got a little bit of erosive changes here. And then, yeah, again, here you can see the markedly flexed anterior scaphoid. So this was
interesting is that the base of the scaphoid has circulation, which is interesting. That looks like a fracture to me, John. Is that, I
don't think so. I think this is just a scapholunate ligament tear, where you can see that the capitolunate angle was fairly normal, but the scapholunate angle was very abnormal, and you guys picked that up. I didn't pick it up right away, but that's what this is showing. Good.
Okay. Yeah, the X-rays didn't show a fracture, but
and this is another case where you see a membranous tear, but here we're getting a little diastasis, and we can see that there's a tear of the dorsal, and probably a high-grade partial tear of the volar scapholunate ligament. Okay, and this is just a low-field scanner showing fluid going through, gradient echo, or it looks like it. Where we get a little higher resolution, we don't really see contrast going through it. And one thing that can happen is you can get these tears, and then they can scar in and not have positive arthrograms. And this just shows a scapholunate ligament tear with a DC pattern, basic DC pattern from the tear. And then we already talked about this. Jennifer, what do you think of this case?
Okay, so here on the coronal image, we can see part of the scaphoid, but we can't see the lunate at all. And then here on the sagittal image, there is some volar displacement of the lunate and kind of a little bit of dorsal displacement of the distal carpal row. So I'm wondering if this is one of the mid-carpal dislocation injuries.
Yeah. So if we go back here, it's probably this one, which is the mid-carpal one. This was acute trauma. So this obviously is an important finding, and this patient has to be treated surgically right away. Okay. Hashu, what do you think of this case?
So 17-year-old snowboarder, where's the lunate?
Where's Waldo?
All right, there we go. So the lunate is dislocated. The capitate actually, I think, has normal alignment with the radius. So I think this is a lunate dislocation.
Yep, good. Jennifer, fall.
Okay, so I don't see much on the coronal image, but on the sagittal image, it looks like there's dislocation of that distal carpal row. The lunate still articulates with the radial surface, so this is probably a perilunate dislocation. And here we have some more images showing the perilunate dislocation.
Yeah. It's, if we go back here, so this would be perilunate, and I go back. This is from Dr. Su. Yeah, this has kind of been between whether it's perilunate or mid-carpal. It depends upon how much dorsal displacement that there's. The cavity. I don't really think it matters.
You have to fix it anyway.
Right. I just describe it.
If you just have that single view right there on the left, that single view, if you see the overlap of the scaphoid and the triquetrum there, can you call there has to be some type of lunate dislocation?
You know, it all again, it depends upon the angle of the beam and the positioning of the wrist. So you really need to look at multiple angles because of that. If you know that it's properly positioned, then it's abnormal. But I've been fooled a number of times with a dorsally or rotally angled beam. You can get very confused. So it's important to always look in multiple planes. Obviously, this would be easy to see in the lateral projection right here.
Which these are acute. The pain is significant, so you cannot position normally.
Yeah,
that's the problem.
I'd be very worried about this, but just remember, because of different positioning and the beam angle, you can occasionally get overlap of bones that can be misleading. So always look in multiple planes.
Right.
That looks totally abnormal to me. So if it's abnormal to me, it should be really abnormal to you guys.
I don't know. You're pretty good at this, John, especially plane films. You've seen a lot of them. So why don't we end with this one? Jennifer, what do you think in this case?
Okay, so we have an 8-year-old male with wrist pain. We can see the physes are open, and we can see that there's some edema within the proximal scaphoid, but I wonder if this is just developmental. I'd want to look at further sequences. It seems like some of that's still cartilage of that proximal scaphoid.
There's a gradient echo. The axial images, you don't see it great.
Yeah, I think that the ligaments. Yeah, the ligaments here look intact. Okay, so incomplete ossification.
Yeah, so this is all just incomplete ossification. But you have to remember that proximal pole of the scaphoid is the last to ossify. So don't call scaphoid. I've actually seen scapholunate dissociation called a few times in these kids on MR examination, so you have to be careful about that. Okay, why don't we stop here? And next week I will be not around. So we'll skip next week, but then we'll have lectures starting the following Monday. Okay?
Well, have a great trip wherever you're going, John.
Well, I wish I were going to Vail. I'm actually going to stay home. I'm going to go to the conference, but it's all going to be virtual. I'm giving lectures in Vail, but I'm giving them from here in LA next week.
Oh.
The miracles of modern technology.
Very good.
All right. Have a good weekend, everybody.
Well, we'll see you guys in about 10 days.
All right. Thank you. Have a good weekend.
Thank you. You guys have a great time.
Thanks.